So I think the future of inpatient OB care is going to move towards people realizing that we've been doing a disservice to moms or parents by not offering these services to them when the general population, the entire rest of the hospital has access to this and saying it's normal, it's supposed to happen, it's supposed to hurt after birth is no longer okay because a total knee is also supposed to hurt. A cabbage is also supposed to hurt, but we don't let those patients suffer. We give them PT, we give them OT. We don't say, "Oh, you had surgery, it's supposed to hurt. You just suffer through it." But we say that with postpartum moms. So I think the future of OB rehab is going to be changing how we view the care we provide moms, and just because something's supposed to hurt does not mean we should let the patient suffer through that pain.
So, welcome everyone. My name is Rebecca Seagraves, and I am the moderator for tonight's talk on the leaders behind obstetrics rehab in hospital settings around the country. We've gotten so many messages and emails ever since Duke Health or Duke University Hospital made an announcement that they saved their system over $500,000 over an 18-month trial period of offering inpatient physical therapy via the high risk pregnancy admission, immediate postpartum, and then also via telehealth services. And that was a pilot program that they instituted, and they now offer both OT and PT services in the hospital after birth and just submitted to the postpartum hospital recovery directory. And so you're all here tonight to just appreciate one thing. Not all of these therapists are representing hospitals like Duke University Health System, and they're representing hospitals where they've made equal impact in my eyes, in my belief, but yet it may not make headlines just yet. And so what we're going to do is we're going to hear from them one by one. They're going to answer the questions as a panel and just introduce you to how their services came about. They're occupational therapy practitioners, they're physical therapy leads, and they've built these programs and they have passion behind what they're speaking about tonight. So without further ado, what I'm going to do is ask each panel member if you will have your video on. One by one, I'm going to introduce you, and I will introduce with an honor Dr. Ano to come to the stage and introduce yourself and your hospital system. And also, the major question that we have for all of you: why did you choose to build or sustain OB rehab services in your hospital? Dr. Ano, welcome, and thank you for joining me.
Thank you, everyone, for having me. My name's Anna. I'm the lead ICU physical therapist at my hospital, Providence St. John's in Los Angeles, California. I'm also the lead inpatient obstetric physical therapist. And the reason I wanted to start this program is coming from an ICU background, I realized a lot of the same practices apply in ICU and obstetrics in terms of the critical care setting, and a lot of the same reasoning for holding therapy or bed rest or activity restriction is very fear-based mentality and less so evidence-based. And I realized the gap that needs to be bridged is just kind of bringing the ICU world into the obstetric world and kind of showing them the very intense patient populations that we're able to mobilize in ICU, and that it's safe to do the same with the obstetric population. So that kind of sparked my interest for starting our program.
So happy you're here, and I can't wait to really dig into it. Excellent. From Michigan, I am so honored and pleased to bring up Dr. Priya. Please introduce yourself, your hospital, and why did you start offering these services and starting to train your team?
Hi, my name is Priya. So I started this program a year ago. So this January, we completed a year. I work at Trinity Ann Arbor. So I started this program in outpatient setting 15 years ago in northern Michigan, and it was an amazing journey for me and very successful. And I felt when I moved to an inpatient setting, I was called a few times to treat patients with pelvic floor dysfunction or pubic pain, or they somehow knew that I specialize in women's health. And at that point, when I went and treated them, I found how much the need we should be there to help them from a therapy standpoint, how to move, how to even take care of the baby, or they are in so much pain that I always saw them in an outpatient world, they are more high function. And I felt the need at that point, and we talked to my director, who was amazing, and also to the chairperson and the doctor the OBGYN chairperson. And we started the journey a year ago, and I felt that was the best thing we did for a hospital.
Excellent. Thank you so much. For those of you in the audience, you're sharing a lot of like who you are, where you live, what your interest in this topic is, and I so appreciate that. If anyone is resonating with you from this panel, please share that in the chat. What you're going to notice is a theme. And for me, it doesn't get tiring to hear this, that all of these therapists have noticed a gap, like our first two speakers and guests have explained. They noticed a gap. They noticed that there were patients that were either on bed rest, but we don't immobilize patients in the ICU. So why would we do that during high risk pregnancy? There were patients who had postpartum issues or conditions. Well, why weren't we offering rehab services early after their experience? We do this on any other unit. So please take down what you're noticing in terms of a gap and the why really behind why these leaders stepped out of their comfort zone and decided to fill that gap. It gives me great honor. Another therapist from Arizona. I will introduce Beth. I'm going to bring you up to the stage. Please introduce yourself and your program, your hospital name, and then also your program.
My name's Beth Compton. I'm a PT, and we've actually had our program now. It's 3 years this month, or excuse me, not 3 years, 5 years. And I work at Dignity Health, Yavapai Regional Medical Center in more of a rural setting in Arizona. And what we do is an occupational therapist and myself, we actually help to co-teach part of our hospital-based birthing center classes for pregnant moms. And then we provide physical therapy evaluations for all cesarean moms, any high-level lacerations or complications after vaginal deliveries. And our start is a little different than what everybody else said. We were actually fortunate enough that our birthing center reached out to us. And that's back as far as 2015. They were seeking to get an Arizona perinatal trust certification. So they wanted us to help them with women that were on bed rest, which isn't the primary population that we see. But I just felt like I didn't know what to do. I tried to give them information. I researched and, did my best. But that's when I started my journey and got my CAP OB certification. They then invited us to do the birthing classes. And then after that, I reached out and got a hold of Ann Krogan, who helped me with my program, and we've started seeing patients there. And it's just, you learn how complicated things can be and how these women really need help. So it's a blessing, and we love going there.
That is awesome. Occupational therapists, practitioners, if you're in the room, please give a shout out. I'm so excited to introduce our OT leads. There's a lot more of you out there, but I had a really difficult time finding you. And so I'm especially excited really to introduce a therapist that I had the pleasure of working with over the summer on a book chapter for acute care, occupational therapy practice and maternal health. Dr. Keisel, will you please introduce yourself and your program?
Yeah, hi everybody. I'm Christy Kiesel, and I'm in Indiana. I actually work full-time as a faculty member at the University of Indianapolis in their OT program, but I live in Terre Haute, Indiana, which is right on the border of Illinois and Indiana. So it's kind of this area that's situated right in the middle of what I would call maternal desert. And I work at the hospital there and started the obstetrics and gynecology program there 5 years ago now. And so that program has grown. We now have a PT and an OT that only work on that unit in those units, seeing those patients. And they screen all obstetrics and gynecology patients. And then they make a priority to see any C-section patients before they leave. We have a protocol that we follow. We try to get in there about 12 hours after they've delivered. So I'm saying they because I'm obviously less there clinically, but I still feel like I have a role there and stay connected to it. We've also branched out in that we're trying to get more in the labor and delivery room. The PT that I work with is such a genius, and she has really pulled together so many resources about how movement is really appropriate for certain stages of labor. And so we're trying to get our foot in the door there because the OT I work with also wants to do some things with the environment in terms of modifying the environment for our labor moms to just make it more in line with physiological birth instead of like working against your body, which is so much how usually the medical model makes it for us women in birth, right? Instead, trying to work with your body, which a lot of midwives already kind of do in the home, or at least that's what we've uncovered anyway. So we're working on that. One way we're doing that is I work with a research group at my university that we're starting to interview patients postpartum to gather that data and try to make a case for why PTs and OTs need to be in the delivery room and not just postpartum, even though that is valuable. And I would argue that we need to be there, in the OB office before delivery even. But anyway, so we started doing a pelvic workshop in 2024 quarterly where we have folks come in, they do their childbirth prep classes, and then the last one is with us where they spend 2 hours with us and we talk about pelvic health and we talk about we show them the movements that they can do through the different stages of labor to try to work with their body and work with baby. And ultimately, I feel like I'm trying to empower them to advocate for their needs, to be able to communicate and assert themselves and have their partner or whoever is supporting them to be able to do that as well. Because those were the gaps that I noticed in my experience delivering babies in 3 different states. So anyway, I also have my perinatal mental health certification. So I find that I'm trying to use those skills as well with the team at the hospital to help them recognize what OT can do. It's not just about pelvic health, which is how they first saw me when I walked in the unit, but now they're seeing that, what OT and PT can provide in a lot of different ways to obstetrics and gynecology patients both.
Absolutely. Thank you so much for sharing. 12 within 12 hours, that's really soon. When we all go around, I have two more that I want to bring up, but when we all go around, I do want to get a sense of if any of you are in L&D, because that's really an interesting conversation, Chrissy, that you just brought up. All the way from North Carolina. Samantha, will you please introduce your program? Welcome.
Hi, my name is Samantha DeJarnett. I'm an occupational therapist at Novant Health Matthews Medical Center, and we just launched our organization's first postpartum rehab program for our high risk cesarean patients and our patients with high grade perineal tears. Very exciting, getting lots of positive feedback. But my why, I have so many whys that I could answer for a year, but I would love to lay it out the same way that I pitched it to our women's division, our providers, and our leadership. And it was kind of the tale of two patients. So a 57-year-old male comes to the hospital for a laparoscopic abdominal surgery. He has a BMI of 32, a history of hypertension, complicated surgery, but the next day is in so much pain he can't walk to the bathroom. What happens? Physical and occupational therapy are consulted. We create treatment plans to address his functional deficits. We make recommendations to facilitate his safe discharge home. All is well. On the other hand, a 37-year-old woman comes in for a vaginal delivery. She has a history of gestational hypertension, BMI of 35, fortunately suffers some lacerations and ends up hemorrhaging. It's not controlled. She's taken back to the OR for a hysterectomy. So very traumatic, complicated surgery. The next day, she is requiring help from her spouse as well as the nurse just to get to a bedside chair. Yet in this scenario, rehab is rarely ever involved. So, why is the standard of care so different for postpartum women that it is for everyone else when we know the data does not support the notion that women are young and healthy and they'll spontaneously recover on their own? So, that is my why. That is why we have to build these programs.
Gosh, that spoke to my heart. I saw the woman who had a cesarean hysterectomy completely unplanned when you just described that patient. So thank you so much. And that was due to postpartum hemorrhage during C-section. So that spoke to my heart. This last one, this is an interesting full circle moment, but Dr. Ano and I were talking about her hospital, that's Providence Hospital in California, and how, her, ultimate wish is to connect with other Providence hospitals in the state. And so that our last panelist is actually an OT lead at a Providence hospital in California. And I don't know that I could have gotten you together on a panel. So please, Mazel, thank you so much. Welcome. Please introduce yourself, your program, and your why for starting and sustaining these services.
Thanks. My name is Mazel. I am at Providence Holy Cross in Mission Hills, which is just in the northern valley of Los Angeles, so not too far away. And yeah, I mean, it would be great to be at all Providences. But my why is I had two of my own C-sections. I've been a OT in the hospital for over 10 years, seeing every diagnosis in every unit. But then I had two of my own C-sections, and my recoveries were both wildly different, but like between the first and the second. And if I wasn't in OT, I don't know that I would have known what to do, and I just felt so lost after my recovery. And I really realized there was a huge gap in services for this population. Same thing, I couldn't understand why people up on the floors who were having abdominal surgery were getting automatic orders and not cesareans who are also taking care of a new baby. So I really blended my love for maternal health and realizing what a gap there was. I was moving after one of my C-sections. I had a toddler after my second C-section. And so just trying to figure out with all these patients how they're going to navigate their home and their environment and everything specific to them when it's so common, everyone is saying, in other areas of the hospital that we're seeing these patients. So started the program back in July and super well received. We're doing cesareans and high grade perineal lacerations with the hope to eventually move to more antepartum as well.
Excellent. That was our last OT lead. Dr. Granger, welcome so much. Thank you. I know that this was a little tight for a lot of our acute care therapists to be getting off of work. So thank you for joining and being able to work us in today.
Sure thing. Can you guys hear me okay?
Perfectly.
Okay. Yeah, so my name's Gianna Granger. I'm in Salt Lake City, Utah, at Intermountain Healthcare Facility. It's Intermountain Medical Center. It's one of the biggest hospitals in the healthcare system. And I think we're starting with the why, and then a little about the program is what I caught on. Okay. My why kind of started in it kind of fell in my lap a little bit. There was another therapist picking up the orders at my hospital when I first came there, when I first started working there. And she was a pelvic floor trained therapist. And then she left and she gave an in service, and it kind of piqued my interest a little bit. So I said, yeah, I'll pick up the consults because at that time, and this is 12 years ago. At the time, we were only getting random orders for those, vaginal deliveries that weren't walking well, things like that. And then I found out what I didn't know, especially in the acute care setting with pregnancy and postpartum. So that started my journey. I took Ann Krogan's course back in the day, probably, I don't even know, before 2020 at this point, and then found Rebecca's course too. And even before that time, I just kept saying the same thing. I'm echo chamber of everybody else here of I work in the ICU. I saw the moms with bad preeclampsia, postpartum hemorrhages, HELP syndrome. I'll never forget the one case that I had that the mom had HELP syndrome so bad, and they did a special thing where they could bring the baby from the NICU over to see the mom on the ICU. I don't know, that really got to me, on top of knowing like same thing. Why are we not seeing these patients after C-section? So after we did an ED program, they finally agreed to do our program. And we started the research and stuff around 2023 and then got the program up in 2024. And we're just seeing cesarean right now. But the nurses are our champions, and they are, hey, I have this mom with a tear. Can you come see him? Hey, I have this mom with a neck injury. Can you come see him? So we have some of that, but it's not a consistent order there. And I will say it's very exciting. This past couple of weeks, I've had 2 patients that are like repeat offenders that I saw back in 2024, which is pretty exciting. And they remember a little bit of what we talked about, not everything. So it's just kind of nice to see, has our program been helpful or not? So kind of that's where we're at this point.
Awesome. A lot of you already answered this in your intro, but our first real question actually had to do with whether or not in your hospitals are services provided by both occupational therapy practitioners and physical therapy practitioners. If so, how are the responsibilities either divided? And so, for sake of just repetition, just for the audience, just to be aware, if you can, again, say where your hospital, not everyone has their hospital, either the name or not all of you have your state near you. So if you do provide both lines of services, will you just start out? If 2 of you are talking, just go ahead and yield to the other. But not many of you actually did have overlapping services from what I understood. But Priya, is that your case in your hospital? Are services provided by both OT and
Both
PT?
OT and PT, we divide and see the patients. But if there is a skilled need from other disciplines, such as we had in the past stroke patients, stroke moms and had a one side weakness. So we make sure the OT see them for the upper extremity needs, like activity modification, ADLs, feeding the baby, positioning. So we make sure the OT see them. Same, I had a couple of amputees and also had a TBI mom with significant cognition issues. So we make sure those patients are seen by both OTs and PTs. But at this point, we have like an outpatient model where, we have a pool of therapists and either OT or PT see them. And depending on the needs, we make sure the other discipline can see them.
How do you determine where the order goes to? If is the order from your physicians just OT and PT, and then you decide amongst
Yeah, so
yourselves?
they initiate both orders. So if an order is missing, the nurses are amazing. They will put right away. We just have to send the communication through like a secure chat, and they right away put the orders in.
So nurses can do a verbal order, and then the
Yeah.
physician later signs off. Okay. Anyone else? Gianna, you
I can
already
help.
said that your
So,
program doesn't.
at our hospital, we have PT. It's me primarily. We're having one of our OTs get trained right now. But the way we've been kind of doing it is PT is the lead. And then if I identify any OT needs, I get our OT involved. But we're also trying to do what Priya just described, where we kind of splitting the duties. My OT is trying to focus more on like the breastfeeding and positioning, more infant care related, maternal occupational roles. And then I'm trying to kind of split more of like the exercise based, more functional mobility. But we're open to hearing any ideas on how other people are splitting it. That's just kind of our preference of what we enjoy treating more, is kind of how we're deciding the split.
So can I just hold you for a little bit just on that, what you're saying? Because I know your work, the work that you're doing in postpartum, I don't think I've seen anything like it. And I don't even know if we have the time for you to like reveal like the things that you're discovering with fetal monitoring and the training that you're receiving from nurses. But do you find that for moms who are admitted, particularly for a longer hospital stay with a high risk pregnancy diagnosis, do they, by any chance, do you ever see that there would be a benefit to having an OT, do an evaluation and just check in with their well-being, with their identity, with how their roles and their routines have changed? Have you seen maybe room for more OT involvement in the antepartum setting?
Absolutely. I've seen, yeah, there's a lot that we need OT for, which is why I actually reached out to some of our OTs and I asked them if they could take some of your courses and other courses to be trained, is because there's a huge OT need, especially when it comes to toileting, care, hygiene. For example, antepartum, one of the biggest concerns is the choreo, the risk of the infection going to the baby. So perineal hygiene is super important. And I think that's way more OT scope of practice compared to us. A lot of the chief complaints I get are related to toileting and showering and dressing and how to dress the baby and how to hold the baby. And I lean heavily on my OTs a lot, specifically the NICU OT, who deals a lot with moms in general. But because she hasn't completed her training yet, we're not formally having them come to the unit until they finish their coursework. But there's so much space that we could use OT for, specifically mother baby co-treatments and having PTC the mom while OTC's the baby, and we're both in the room together and we're co-treating on different patients, but the activity we're doing is the same activity. She's working on the baby, I'm working on the mom.
Awesome. I always say this, and I'll pause here. Some of you, and I appreciate this, have mentioned my training, but I said to myself, if we were doing a good enough job, we would be training you all to train your teams. And so there is another Providence Hospital in California with an OT lead. And Mazel, I'm going to tag you just to kind of, pipe in here, but specifically, how are services divided in your setting? And then also anything that you want to say for antepartum services and where you feel OTs can really benefit. And then, any future goals, maybe possibly that you may help to train some of the OTs at the other Providence hospitals as well. That's a huge, oh my gosh, I can't believe she said that, but I'm throwing that out there as well.
Yeah, so we just have OT in our postpartum right now. When we were starting it, it was kind of my little brainchild passion project. And it's just OT. PT does get the occasional order for pelvic pain or weakness after delivery. But in terms of like the day to day, it's me. And then I've been training all the other OTs. So I created a competency checklist for them. Having every other OT come observe me, then me observe them. I gave them in service with all the good education, and slowly we're checking everybody off so that everyone feels competent. We're trying to navigate how it works. It's just a very different beast down there than it is on the acute floor. So everyone's having like has to stay in their lane a little bit more. And so we weren't sure how to do OT and PT together without duplicating services. And then it doesn't really work to order both of us at our in our system and then pick and choose because then another person's not addressing their order. So we weren't sure how to figure that out. But for antepartum, we get the occasional order, and I'd like to definitely beef that referral system up. I had a patient who was just on bed rest for 6 weeks. PT initially did the eval, discharged the patient, and then we followed up like a month later. And so just because there wasn't a program in place to really like stay seeing the patient, and I was telling Rebecca, like, she got up after 6 weeks for the first time because she was on strict bed rest and couldn't stand, needed a walker, sent her home with a walker, and, like, we just have so much room in there to work on things in bed for those strict bed rest patients, and then figuring out what the doctors are okay with to start doing activity. So that's my 2026 project in addition to, training, and then I would love to reach out with other Providences in LA because there's a lot of Providences down in SoCal to get this program going everywhere else too.
I could feel you shift in your seat, and I'm just like, in 2026,
I
we
know.
just sent a mom home who was on strict bed rest with a walker. How does one
Oh my goodness.
navigate postpartum recovery? Oh, no, I'm not gonna hold anything back. Do you wanna say anything to that?
Strict bed rest in 2026 is crazy in my opinion. Like,
Yeah.
coming from an ICU perspective where my patients are on ventilators and ECMO, and I'm getting them up and having them play soccer and basketball, and they're on 3 pressors and, and then coming to the antepartum side where it's a whole different beast. So where I work is I work only really with the antepartum population. We have a few other therapists at my hospital that see the postpartums, but because of my critical care background, all of our antepartum patients are up and moving around. We don't really do bed rest at our hospital anymore. We do ICU style up and moving. So I'm interpreting the baby monitors the whole time. The nurses sat me down one day and they said, "You're learning baby monitors today." And they did a crash course for me on how to understand all the monitors. So I told them my eyes are going to be glued on that monitor. If there's any signs of fetal distress, anything's happening, we're going to stop. They know how our ICU program works and how aggressive we are in our ICU and how patients that are knocking on death's door are still able to get up and that they actually do better after exercise. So I don't know how this OT scope of practice works in terms of like monitor interpretation. Cause I know in PT school, we have like several lectures on EKG interpretation and lab interpretation. So kind of the scope of practice kind of bleeds into like other kind of monitors. Same with an ICU, like I do my own ventilator monitor interpretation and same with if they're on a hemisphere. So I think the scope of practice kind of bleeds into any type of monitor interpretation under the supervision of an RN. But that's kind of what we do is I get the moms up and I do like an ICU style progression of activity of going very, very slowly and just assessing activity tolerance with like every minor thing we do. But we have them like up, walking, exercising, and they don't go into preterm labor. Spoiler alert, they all make it full term. The babies are fine. The babies come out fine. There's no infections. So it's safe and we're able to do it. You have to treat it like it's an ICU patient. You have like that level of extreme caution.
Chrissy, I'm just gonna tag you because you're actually teaching OT students. And in terms of just scope of practice, Samantha, I think that you can chime in. Mazel, you could chime in after. But monitors, yes, I'm sure. Please just chime in if you can.
Yeah, I mean, I'm just over here nodding my head to what is it Anno? Is that how you say it? Anno?
Oh no, yeah.
Oh, no,
Um,
sorry. Yeah, I'm over here nodding like, "Yeah, that makes so much sense to me." Like, why wouldn't we do that? I feel like in our unit, we've been doing that with, like, blood pressure monitoring, right, for preeclampsia, for example. I know that was a big hoop I had to, like, jump through with a lot of our medical staff on our unit. When folks were antepartum on bed rest for preeclampsia or hypertension, they would get freaked out when I would say, "I'm gonna walk them, but I'll be monitoring their blood pressure, right, before, during, and after. I'll let you know if there's anything that we should be restricting in terms of movement, right?" but I'm the activity guru, right? Like I'm the person that knows what they can and can't do in terms of activity. If I know what's going on with their body from the chart, then I'll let you know, right? If I think it's inappropriate. And I think they need, I don't know, for me, my staff needs to know that, right? Because they're just so used to, like the nurses are so used to taking the order from the physician. And in my experience, the physician is just writing those bed rest orders because that's what they've always done, right? They didn't have really another alternative. So then my voice coming in and saying, hey, what about, this is how we do it. Like you said, Anna, like downstairs in the ICU, or how we do it on the med surg floor, right? And I think when they hear that and then they see the result, right, of me actually being careful and monitoring, I think that helps, or it has helped, at least in that realm. I love the idea of kind of expanding that beyond blood pressure. And we haven't really done that. So I'm writing down notes like, oh, yeah, we should definitely be doing that. I love that idea.
Absolutely. I do too. For all of you who are kind of getting the gist of the conversation, and who are type A people like me, and you're like, Rebecca, you skipped over. I didn't. I just moved ahead because we were on the topic. But high risk antepartum is really not captured on our directory, which many of you have submitted your hospitals to. We don't actually list whether or not you're providing antepartum services because in Ano's case, this is still a developing area. Even from what we've taught, we were really looking at blood pressure. No one's reading or interpreting. I mean, I don't want to misquote you. Ano, we're not interpreting fetal monitors, but at least being trained on what it means. Would anyone on this panel feel pretty comfortable in watching the fetal monitor while working with a patient on bed rest? Beth, you gave a big head no. Mazel, you gave a big head no. Gianna, you did too. Samantha, you did too. Anno, do you think that there's room for your services coming from critical care and bringing that critical care and piece to high
Mhm.
risk pregnancy? Why critical care? Why would that title or area of practice in rehab in the hospital apply to this setting, high risk pregnancy?
So I think the biggest thing they have in common is so in ICU patients are usually 1-to-1 or 1-to-2 ratio. And I realized that labor and delivery antepartum is the same ratio. It's usually 1-to-1 or 1-to-2 ratio. And in terms of the acuity of the patient and the fact the what could go wrong and how catastrophic it would be if it went wrong. You're right. I feel like that same thought process applies in the ICU as it does to antepartum. If something goes wrong, it's going to go really wrong, and I feel like that's kind of what makes somebody a critical patient, especially in antepartum. You have two patients, one you can see and one that's inside that you can't see. I think that automatically having a second patient inside that I can't have eyes on automatically makes somebody a critical patient for me. And using those same practices in the ICU of like, a huge concern nurses had is what if they trip on the cords? It's too many wires. It's not safe with these wires. Or what if their blood pressure drops? What if they fall? And them not knowing that, I just got up someone who was 450 pounds on two pressors, on fentanyl, on propofol, and he didn't fall. And even if he did, I would have just caught him. Where PTs, it's fine if patients fall, we'll just catch them. It's literally what we do. They're not going to hit the floor, we'll just catch them. They were like, oh, we never thought of it that way. So I got a couple questions in the chat about how this went to be. The easiest thing is invite the doctors to come watch. I invited all the OB-GYNs and OB anesthesiologist. I said, come to ICU one day and you can just watch what I do. Same with the L&D charge nurse. I said, just text me if you want to come watch and see how we're doing things in ICU. And they were shocked. They were like stunned. Having them watch does a lot more work than doing a presentation because you can tell them all you want, but it's so much more different when they come. And then the L&D charge nurse talked to the ICU charge nurse and she was like, is this real? Are you guys really doing this? Like, and hearing it from a fellow nurse made her feel a lot more comfortable that like, yeah, this has been going on for years. It's totally safe. So it kind of did the work for me.
Excellent. I'm going to now zoom out and really for the people who are in the room, I'm constantly monitoring because there are people in the waiting room that are trying to get in. This topic was so popular that I reached capacity before I even knew it. So I had no idea. This is why I really feel strongly that yes, Duke University Hospital made headlines. We want to see that in our field as rehab therapists. We want to see a hospital say we saved them money. We want that validation. But not all of us are measuring hospital readmissions, are we not? Some of us are in critical access hospitals or rural regions. Not all of us are in level 1 trauma centers or maybe even having the data to even know how many patients are being readmitted back to the maternity hospital versus back to another hospital because they're no longer pregnant. How do we actually capture the data that Duke did? And you're not Duke. But what you're saying tonight, you're making headlines with what you're doing. And so, Samantha, I'd like to give the floor to you because one of the questions for you as panelists, please answer. I want to hear from all of you. How are these referrals actually being generated? Like, who typically gets seen? But Samantha, if you would be so kind to actually do a little bit of a deep dive as to how you got the attention of your hospital C-suite, of your CEO, and of other hospital CEOs around North Carolina. I think that your story is particularly amazing. So if you can answer that question, but then give a little bit of a deep dive of your system.
Sure. Again, I'd like to emphasize we're still in our infancy. However, this came to me and I reached out to our women's nurse manager and, pitched this. This is why we need this. And she was immediately all in and asked me to come present to our women's division in our hospital, which included providers, leadership, and specifically our chief nursing officer, so they listened to me present, why we need to be there, what we can do for their patients, like I told you, my initial pitch. And they were so receptive, immediate buy-in. Immediately, everybody was all in. And so now kind of filling in the operationalizing it. And our chief nursing officer was so excited. He immediately went to our hospital president and was like, oh my gosh, this is what we're doing. And so some of our other leaders I was talking to today said they can't go to a meeting without hearing about it, which was really exciting feedback. Currently getting our referrals, I got approval to do a screening process in the electronic medical record. So I can kind of see our labor and delivery patients, and I can kind of sort a list that I can easily identify who's meeting our criteria, send a consult to the provider. However, we're also gaining a lot of traction, like someone else said, with our nursing colleagues. As they're getting to know us, seeing our value and what we can do for their patients, they're asking for us to come and be there and be involved in their care. So that's really now becoming a big way that we're getting our consults as well.
Excellent. Gianna, what are the criteria that you found? I know that your criteria is maybe a little bit more narrow. You did mention that, with cesarean deliveries, but you're starting to see more for peritoneal tears, third and fourth degree tears. But then also, I think you have some interesting things to share from the overall feedback that you've gotten from nursing and patients. Is that right?
Yeah, yeah. So when we did pitch our program, we were asked to keep the scope narrow. So we did look at moms. So it was C-sections, but moms that with morbid obesity, diabetes, any like pre-existing conditions or MSK conditions. I will say that was a little confusing to the providers, but it's what we did. It got our foot in the door to be able to see these type of patients. And then yeah, I mean, the nurses, once we started telling them exactly what we were doing and who we were seeing and where the benefit was, I will say anytime I see a nurse walk to a room with a waffle cushion, I'm like, hey, what's going on there? Can I help in any way? They were really on board. And we did our pilot project. We did a nursing satisfaction survey and kind of asked them, like, did it affect their workflow? Did they see that the patients were mobilizing better? And then feedback that they had. And the feedback from all of them was like, yeah, my patients are moving so much better. There was carryover and at the nighttime, and night nurses were seeing, yeah, the patient said, the PT told me how to move this way. And the aides in the evening were saying that the patients just moved safer. So we were getting kind of carryover from our night nurses too. And they actually asked, can you work at night? Can you come in the evenings and help us mobilize our patients? And then the overall overwhelming request, because we do not have our orders on an order set, was, can we have it on an order set so the doctors don't have to put the order in? So we're still working on that. But yeah, they've been amazing. And then our feedback too, and I don't know if you were referring to the patient satisfaction surveys that we got as well. We pushed it hard in the beginning. We literally just did a QR code, Microsoft Forms, asked them 4 questions about their satisfaction, what was beneficial. And then if this is not your first C-section, did you still learn something? Because that was a concern too. We heard from nursing, like, they already done this before, they're fine. And when we got over 110 responses in that first year of the program, and overwhelming, like paragraph long comments from these patients about how beneficial it was. The moms that had 5 C-sections still found something beneficial. So I would push, if you're starting a program or if you haven't already, get the patient satisfaction surveys and ask the nursing staff, because that also helps show value, even though it's a subjective measure, but it still shows value. And we've gotten a bunch of kudos from our executive leadership team that we've talked to, nursing and all that, about, wow, this is amazing that the patients have been responding so well. Because the surveys they get in the mail, the little, maybe a couple comments here and there, unless it's a bad thing, that's when patients write a paragraph. So that would definitely help your program development as well.
Excellent. I love to hear about the impact on nursing workflows because that's probably of most interest. And Samantha, you can either nod your head with most interest to the hospital C-suite, to the administrators, is how is the whole system moving as a whole?
Absolutely. We're able to capture things that maybe, nursing is struggling to capture education wise, that they're, falling behind on the, not, I mean, our nurses provide excellent care, but just, we have a little bit more time to dedicate to certain things that maybe we can help fill that gap.
Excellent.
And
But to
I'm just
piggyback off
gonna
the patient
oh,
satisfaction,
go
sorry, Gina, we're
you're good.
actually using the readiness for hospital discharge postpartum scale and collecting that data to see, are we moving the dial on, how confident patients feel in their discharge to go home and how much therapy helped with that.
Any other outcome measures that any of you, in popcorn style, please, because Beth and Priya, I want to hear from you on the same question, but outcome measures, anyone? Beth, you can
Yeah.
unmic as well.
Really quick, we used the
sorry.
obstetrics quality of recovery score. We're going to be sharing our poster as well as a little bit more data on that, but that was more of a patient-reported outcome measure, and it asked specific questions about infant care too. So that was kind of a nice one to measure if they felt ready for discharge. It's a little
Amazing.
shorter than the other.
Samantha, are you using the full 18-item readiness for hospital discharge?
Short form. We're using the
Short
short form, the postpartum short form.
Okay. I would love if you, Gianna, if you have the ability, or either Samantha, if you can put those outcome measures in the chat, just so that people in the chat, there's a lot of questions that I'm not getting to just yet. But Beth and then Priya, can you describe how are orders generated on your units, and then what's the overall satisfaction or feedback that you've gotten?
Our nurses are very happy and they do advocate, like everyone else has been saying. Like a lot of our non-cesarean consults, that's all nursing saying, oh, can you come see this person? This person's having this issue. Our order set, when we set our program together and we met with the OB that was in charge of that department, we got our orders put as a standard. So it's a pre-checked order on their post-op order set for day one for PT. So if they didn't want PT, they'd actually have to uncheck that. So that's how we get our cesarean. I also am in direct communication with the charge nurse. So if I don't have any OBs for that day, I'll probably just call down there and say, hey, it's Beth from PT, just checking in to see how you guys are going. And then they'll let us know there. As far as outcome measures, that's something that I really would like to start. I just always talk to the patients myself, and I'll be like, oh, was this helpful? Or especially like our repeat cesarean moms who maybe didn't have these services on their first time. I always ask them, what did you think about this? And they're like, wow, I really could have used this last time around. So, but I would like to institute some more questionnaires.
Excellent. Priya, would you speak to any of the outcome measures that your team is using?
So we are not using any outcome measures, but I just reached out last week to our OBG chair. So one of the resident might be interested in, like, since we started the program, how things, so he or she will be trying to do a project on it. So I'm doing like a presentation to my 60 providers and 20 residents on positive impact and what we are doing. So if one of them are interested, we are going to so one of them should be taking over to do that satisfaction survey. But I love the idea of doing like a patient specific or something similar, like some of you have mentioned. But also our nurse manager rounds every patient prior to the discharge, and I always get subjective feedback, but not anything in writing. So, like more like a formatted versions, which I would love to. Yeah.
Excellent. And you mentioned this before in your intro, but just for sakes of the audience who may have came in after, can you just describe how are orders generated for the patients who get seen? Because you're also doing something pretty unique with manual therapy, TENS.
Yeah. So like Beth mentioned, all the C-sections, we get the PT orders automatically generated. It goes with the standard orders. So OT, we are still in the process of working with it, but the nurses are pretty great. And we just have to send a communication message and they will start generating that right away. Regarding the TENS so I felt like a big hit coming from the outpatient. I'm like an orthopelvic therapist, so I do love manual. And implementing that into the acute care setting changed my life. Like I feel like nurses just wait when a patient is in a desperate pain, whether it's neck or shoulder or back, pelvic floor, perineal, name it. They will let you know. I know few of my coworkers are in this meeting too. So like they desperately need you to do some hands-on, and you can see right away the results. And I make sure I update the providers that what's difference we made in their life, getting them out either like discharge on the same day, not any more prolonged hospital stay where they cannot get out of the bed because of pain or whatever that musculoskeletal issue was, we can address. You don't need to be in that outpatient setting. You need to have much, like lot of visits. You can make some difference when you try it. Unless you try, you won't know it. And same with the TENS. So we educate all the nursing. So we introduced TENS in labor. So all the nurses are trained in that. And we do have TENS unit in our labor and postpartum at the mother baby unit. So anybody with C-section pain, gas pain, or musculoskeletal, once therapist has evaluated and they see the need and tried it, the nurses are educated and trained on the same as well. We see significant change in their mobility and pain with the TENS in the postpartum and the C-section. C-section pain is one big one we use as well. Same with labor. Some of them don't like the pharmacological aspect of the, like the epidural or anything. And the other option we have is the nitrous. And we do have like other options, but we introduced TENS as well. And it made a significant difference. And I get a lot of provider email feedback saying when it was introduced. But prior to that, we gave like a big presentation and a lot of evidence based why we are using it. And that helped a lot too.
Excellent. Is anyone else in their hospital using TENS on the panel? Gianna, you're using TENS. Is it during L&D or is it postpartum,
No,
like the C-section?
no, it's trauma patients mostly, not my postpartum.
So not
But
OB.
no, I'd love to learn more about this for gas pain, though. I put that in the chat. That's the one thing I'm like, I wish I could help you with, and I haven't found a method to help with the gas pains. I'd love to
Amazing.
learn
The
more
ball
about.
massage and the abdominal massage, but the TENS, if you literally look at it, you have those ball pathway, you can set it up and you're helping to move things around. And even like if they have abdominal muscles are already strained, that TEN helps to release a lot of discomfort as well. So
Excellent. Is anyone else practicing on L&D or either? We talked about antepartum and then immediate postpartum in the hospital, but any L&D, anyone else who's helping out L&D?
So we taught a lot of positioning we don't personally in person there for the labor or the active labor phase, but nurses education is an ongoing thing we are doing, like positioning and, breathing techniques and how to push, all those things are in the process and still like an ongoing training we are doing. So
Excellent. And then just show of hands, is anyone else involved in nursing education or even cross training? Are nurses also training your team? Like I know you've received training from nurses, on fetal monitoring, on high risk pregnancy. So all of you at least are cross involved in nurse education. So you're really working closely with your nurse teams. Is that right? Excellent. Well, we have barely enough time for one question. But you all actually did a really great job of answering this in your own way. But I want to hear now from each of you as a close. The last question I had for you all was, how would you describe the role of OT and or PT? Don't feel like you have to speak for another discipline. Actually, please don't. But how do you describe the role of rehab in high-risk pregnancy, labor delivery, early postpartum recovery during hospital admission? And you can ask for, or answer this question as a general, like just for the people in the room. There's a lot of people in here that are not necessarily representative of our field. They're just really curious. I never heard of rehab on the maternity unit. I didn't even think that. I practiced for 50 years. We never had an OT or PT on the maternity unit. Our moms were fine. Why is this even a topic? For those people, please answer the question also. But speak to your setting, speak to your practice. We're going to start with Christy.
Gosh, you would start with me, Rebecca. Okay, can you repeat the question that you want us to answer?
Yeah. How would you describe overall the role of rehab in these different aspects of maternity care, high risk pregnancy, labor and
Okay.
delivery, early
Yes,
postpartum
thank you.
recovery?
Okay, I remember what I was going to say. So the thing that comes to my mind is really about reducing fear avoidance behaviors. I feel like across the board, by us being present and active with these patients, antepartum, postpartum, it helps tremendously for them to recognize what they can do, right? Instead of focusing on what they can't do or what they're afraid of doing or what they're afraid of damaging, if that makes sense. And so they're it seems like in my view, they're becoming more active, they're getting back to their life, they're becoming more functional.
And Chrissy, just to end, can you remind everyone of your hospital, like the setting? Is it a trauma center? Is it
Yeah.
rural area?
It is rural. Yeah. It's very yeah, it's rural. So, I mean, we're not I think we're a trauma level 2, if I'm being honest, but I always get mixed up with those trauma levels, so maybe we're a 3 because we have a pretty good NICU, but a lot of times we have to transport folks to Indianapolis, which is the nearest, like, big city hub, so and that's, like, an hour and a half, 2 hours away. So, we're pretty small. We have about, I wanna say 30 beds on our postpartum unit, but some of those are designated for antepartum and gynecology patients as well. So, we have about 6 patients that are delivering a day.
Excellent. Thank you.
Mhm.
Beth, will you speak to your hospital? Like what do you how would you describe the overall role that rehab has played in the maternity setting in the hospital?
I think that for us, it's really prioritizing the mom. I think this is a time, like, when you're pregnant, all the attention is on you. And then here you have a baby, and all the attention goes to the baby. And I think this is a time where we can prioritize the health for the mom. We can sit there, ask them questions, find out what's going on with them. I feel like it's a unique opportunity to catch things. Like to have those conversations. Did you have some issues with your bladder leaking? Everyone just thinks that's normal. Today, even I had a woman say, she's like, "Oh, just the normal stuff." And I'm like, it's common, it's not normal. And to catch the women that maybe are having pain with sex, and maybe they've had pain with sex for a long time, and no one ever told them that that's not normal. So I think it's an opportunity to prioritize the mom and her health and then educate them and teach them how they can best support themselves and help them be successful at home.
Thank you so much. Samantha, you actually started out with almost like a story. You pulled us in really with that case scenario when you did your intro. If OT and PT services were just not offered anymore, say this all fizzled out in a decade from now, maybe some of us are still practicing, maybe some of us have retired, whatever. But say it just fizzled out and no maternity, hospital in the US is offering rehab services anymore. How would you think that would impact even the patients that you've seen in your own practice so far?
Oh my gosh, I think it would be so sad because even the patients we've seen so far, every patient that you go to see says, "Oh my gosh, I'm so glad you came. I don't know what I would have done." For this week, a patient told me, "You've been in my room for 2 minutes and I already feel better." So that would break my heart if it all fizzled out. Yeah, I think that would be a shame and it would really be an insult to the progress being made in women's health. I think our role in rehab is to empower women with the skills and confidence they need to perform their functional demands when they leave the hospital, as well as equip them with the education and knowledge to protect their healing during that time while managing those functional demands, maintain and manage their own health, and be able to advocate for themselves when things don't feel right. I really passionately feel like we have a duty to elevate the standard of care and make sure that postpartum women are getting what they need and what many other patients in the hospital are getting.
I know. I think almost a year ago, you would not have described yourself as someone who even wanted to be on the maternity unit. You are a critical care therapist who've trained under the likes of, some of the leading ICU therapists in our country. And you're now on the maternity unit and paving a massive trail in acute care obstetrics, specifically high risk antepartum care. You can have a crystal ball and you can see into the future. Where do you see the future of rehab specifically for this patient population? But even speaking to high risk pregnancy, what's the future of rehab in the hospital after and before birth?
I think the future is people are going to start to realize that a pelvic patient is an orthopedic patient, and there's no reason why, if a total knee is getting seen 2 times a day, why would a pubic symphysis separation not be seen 2 times a day? I think the future we're moving towards is people realizing that there's nothing different about postpartum, antepartum, pregnant, peripartum, whatever you want to call it, patients. Have orthopedic impairments, they have cardiovascular impairments, they have the same impairments as other surgical patients do. So, what is the determining factor that somebody who had an elective total knee, who chose to have that surgery done, gets PT 2 times a day, but somebody who created life does not have PT 2 times a day when both of them have an orthopedic injury, A pubic symphysis separation is an orthopedic condition. Vaginal perineal tear, that's like an ankle sprain. It's like tearing your ACL, tearing something in your ankle. C-section is a regular abdominal surgery. I think the future is people are going to realize if you get your gallbladder removed and you get a PT consult, you should definitely get a PT consult if you had a baby removed. It's not any different, in my opinion, than a regular acute care patient. A hemorrhage patient is a patient that had a code MTP. It's a patient that bled out. They're going to have the same cardiovascular deficits, the same blood pressure deficits. So I think the future of inpatient OB care is going to move towards people realizing that we've been doing a disservice to moms or parents by not offering these services to them when the general population, the entire rest of the hospital has access to this, and saying it's normal, it's supposed to happen, it's supposed to hurt after birth is no longer okay because a total knee is also supposed to hurt. A cabbage is also supposed to hurt, but we don't let those patients suffer. We give them PT, we give them OT. We don't say, "Oh, you had surgery, it's supposed to hurt. You just suffer through it." But we say that with postpartum moms. So I think the future of OB rehab is going to be changing how we view the care we provide moms. And just because something's supposed to hurt does not mean we should let the patient suffer through that pain.
Gianna, you are pumping the air, and I'm going to tag you after that. I don't even know who can follow that. I cannot. Ano gives me chills because she's only been out 3 years. I'm sorry, Ano, I had to say it. You've only been out 3 years, and you give me goosebumps when I talk to you. Gianna, if you can answer that in a different way, because there are people in this room who still can't even get consults on the maternity unit. Not on antepartum, not L&D for sure, not early postpartum recovery. They're sending moms home. I shared a story recently of a mom that was sent home in a wheelchair, Dr. Catherine Sylvester. She's usually in the room when I'm speaking, but she called me and this woman couldn't get up her steps. So she was toileting in a bowl from her couch for 5 weeks before we were able to get, someone to come out to the home. But that was all Dr. Sylvester trying to get a physician to then do a home visit and order OT and PT. But this woman was sent home from the maternity unit in a hospital that didn't offer our services. So for the people in the room, Gianna, if you can speak to them, if they are not getting orders, all of you represent less than 10% of hospitals in this country that even provide rehab after birth, less than 10%, right? So for those people in those hospitals, what do you have to say? What's your message?
I was so enthralled by Anna's comment there. So I don't know the original question, but my message to those fighting to get programs, kind of get this up and running, are those stories. If you know those stories, reach out from family, other therapists, things that you've heard from patient care and share the stories. And that's what I've learned a lot from Rebecca over the years too, and that's what drove me to her programs is the stories, the messages to kind of share that. It brings it home. And that's how we got our program up and running a little bit too with our admin of, you were moms once. How was this for you? And kind of really making them recognize that. And I'll share a story too. I have a student right now, and she just told me a mom, she had already had a C-section before, and we went and saw her. We taught her how to do stairs, and she told me, "Oh my God, the last time I got home, I had to crawl up and down the stairs because I couldn't get in and out of the house." So like that right there, you just really need, it just pulls on the heartstrings, and that I think is the best way to kind of get in there and help people recognize the benefits of getting these programs up and running and what they're going to do for patients. We know it. And that's the thing. I'm like, duh, why isn't common sense? And when I started talking to more people, the light bulb wasn't there until you shared that message. So I just keep spreading the message. Hopefully I answered
Excellent.
the question that you
Think
were
you did.
asking, but
Yes, you did. Priya,
yeah.
you have 21 years of practice as a therapist, 14 of which have been in women's health. I heard you and Ano kind of allude to this, but more training is needed. More training is needed, right? For therapists to feel comfortable of treating patients in this setting. Priya, you've brought manual therapy to acute care in a way that, to specifically maternal health, in a way that I haven't even seen, right, from my own practice, and I teach in this area. Where do you feel like there are some of the biggest gaps and opportunities for therapists to either learn about, educate, self-educate if you have to, like Ano's doing, because there's just nothing that even is guiding her except the nurses and the other staff in her hospital. Same with you, Priya. You're bringing so much experience from the outpatient and women's health setting. Where can people get started who just want to really just treat this patient population, like where do they start? What's the simplest way? No high-end courses, nothing like that. What's the simplest way to get started?
So in my setting, so currently I do a lot of manual that I feel like that's my strength. Even just not the mother baby, if there is any like pelvic issue patient, like, sometimes you get a message from your other team members like, hey, she's in a lot of, so I do visceral mobs too. So I feel like at that point, I feel like at the basic level, if we can do manual therapy in different way in one particular muscle. You have that vast variety of techniques you can do. One way in my setting I'm trying to do is like we have like an education committee. So I did talk to the education committee chair. Starting, it's not that everybody's thing. Not everybody likes to try manual. So find a group of therapists and we can start with the basics. So that's where I'm starting. And hopefully in next couple of months, we are going to start that initiation and during lunch or lunch and learn, something like that. So that's the hands-on lab technique we are going to. And I know eventually I want to start. I feel like I didn't know that it's, I just joined your program for the specialization for the certification. And I know you talked about that manual is not something we cover. And I feel like I need to start talking more about it, patient experience and results. And I want to bring that into the acute care world. I feel like that's something I'm excited into right now. And I really want to explore it. And it's like I said, I repeatedly say it doesn't have to be a ton of visits. You can make a difference in 1 or 2 visits in their patient. Last 1 year in mother baby unit, and even in antepartum, because they are in the bed or in the recliner, I get them out of there, take to the gym, and they feel like a human. You're doing basic manuals or stuffs if they need it or as indicated, and they feel like psychologically they are in much better place. They don't feel scared. They don't feel like, why am I so tight? Why am I back hurting? So even just the basic modifications and exercises you're teaching, some hands-on and then self-stretches, educating them helps make a huge difference. So I would love to introduce manual into the acute care world. I just saw like in February, there was a APTA meeting, which talks about the manual skills in acute care. It's not an outpatient thing. It's up in, I don't know the details, but there is a research out in there in Google. If you Google APTA for the manual for acute care, it's up there. I don't have the details, but I'm
Is that
looking
Rebecca
forward.
Griffith,
Yes,
PD,
I just
CPT?
posted the details in the chat.
Great way to be on it. If my crystal ball is right, I think that we're going to see a lot even from you on this panel. I mean, I'm just going to say that there's going to be trailblazers that are paving the way in education for high-risk pregnancy and for manual therapy specific to the OB population. That's my crystal ball, is that the people on this panel, the people in this room even that's joining us, you're going to see a lot coming from this type of energy. And I never thought that our course would even cover half of everything that this is a whole population. I mean, that's like saying my course will cover everything you need to know for orthopedics in the hospital. Yeah, right. Right? There's no way. But it was always meant to end as an avalanche. Start as a snowball and you end as an avalanche, because I really do think that the only way that we can see any progress is through a movement and not through one entity. Mazel, if you can bring us home, this is a question that's burning on my heart and soul. And I want to end with this, but really, I see the benefit of offering both disciplines in the hospital. I really do. But if we can only offer one, knowing what we know about the future of both of our professions, there may not be enough OTPs, there may not be enough PTs. How can we show up more so, either differentiating our services so that there's not overlap, maybe working in areas that are really areas of need, not to step on toes, but mental health in this world is huge. To send a patient home after strict bed rest, that's huge. And that's a huge aspect. And we don't want to step on toes. Social work is doing mental health. We don't want to do mental health, even though you're trained in it as an occupational therapy practitioner. How do you see us differentiating our services in the future so that there's no question as to why we're here on the team ready to help? No
Oh
pressure.
man,
Last
no
question.
pressure. I mean, I think we all come with our own lens. I think the OT lens is different than the PT lens, different than the social work lens. And I think with patients, you're bringing that special sauce, if you will, to it. And I think there's always room for everyone because we are going to focus on different things, even though it looks the same. I mean, a nurse today was like, "I thought you were PT," like, after all this time. She's like, "What is the difference?" And there's so much overlap, especially in acute care and in the hospital setting. A lot of what we're doing is really just, we want our patients to get up, we want everyone to move, early mobility, but then our goals are different and we see things differently. So I think as these programs expand and as we get more buy-in in maternal health, like, we're gonna have more access, hopefully, to really advocate for each service being there. And I think exposure therapy is the way to go. I mean, starting small, and once people see what we're doing, they really get that buy-in and they're like, "I wasn't sure about you at first, but now I see what a difference you're making," and our patients are saying how amazing this is, and I didn't know that therapy even did this, or I didn't know that's how you're supposed to get someone out of bed. And having them see it, having the nurses see it, having the doctors see it, the recovery really gets people excited about it and realizing what we can bring to it. And I think if we each keep bringing our special sauce, that we're able to find roles for each other. I think starting a new program, it's sometimes easier to have one discipline start first just to figure it out and figure out the kinks in terms of like management and being willing to back you. And then as it gets going, there's room for everyone, hopefully, when you get people engaged. So, I mean, I hope that we can all bring it all, and I would love to address more mental health, finding ways to not step on toes with other disciplines, but all being able to bring what we do best to help the patient.
Excellent. I can't thank you all enough for participating on this panel, for going over time with me. I always say I'm the liar when it comes to that. I really do try, but I've not been able to do that in probably now 3 or 4 years that we've been doing this. But please, if you're in your car still, in the office, at the hospital, thank you so much for just taking the time out. I will go through the chat. I'll go through the comments and the questions and share those with you all. And if you want to share any of your contact information, if you haven't done so already, please put that in the chat and I'll make sure that people can get in touch with you and just follow your work. You're making headlines. And in my belief, I think you're blowing, what Duke did out of the water. All respect to Duke. I went there, I graduated as a resident, but I think that what you all are doing, you're furthering this movement in a way that I've never even got to experience when I practiced in the hospital. And now I'm on the telehealth side of things, seeing this patient population the first week after birth. So that's even exciting and more to come on that. So thank you so much for sharing your work. And I can't wait to see where your journeys end up and the teams that you'll train and the hospitals that you will influence. Thank you all.